Hello and welcome to the RCPCH webinar Facing the Future Paediatric Standards with Dr. David Shortland, Consultant Paediatrician at Paul Hospital NHS Foundation Trust and RCPCH Clinical Lead for Facing the Future. If you have any questions, please submit these through the questions box and they will be addressed at the end of the presentation. I will now hand over to David, who will begin the presentation.
Well, good afternoon, everybody. I'm going to talk today about facing the future, and I'm going to divide the talk into three sections. In the first section, I'll talk about how we've developed the standards, and so some background to facing the future and what we've been trying to achieve with the work stream. In the second section, I'll talk about the new standards, which have been entitled Ongoing Healthcare, and these are really relating to children and their families who have been referred to or who are actively under the care of a child health department. And thirdly, I'll talk about the national audit of the previous two Facing the Future standards. And I'll say at this point that I know for doctors the word audit is a little bit of a turn-off, but I wanted to stress the importance of this part of the talk, because I think that when standards are produced by professional bodies, there is a responsibility on those bodies to see whether the standards are actually being met in practice. And I think equally as importantly, when you produce standards for Face the Future, which are largely service standards, it's difficult sometimes to find the evidence base for these standards. It's much more complicated looking at service standards, I think it is for clinical standards. So when we produce these standards, we think that they're right, but we don't know that they're right. So it's only really by auditing the standards, I think, seeing if they're being met, seeing what they're achieving, seeing if they're not being implemented, and understanding the barriers to implementation. I think we understand the standards better. And as I'll come on to in a few moments, I'll talk about the way a previous audit has shaped the standards. Now, coming on to the second slide. I was asked to give this talk a couple of months ago up in Glasgow, and I think it started me thinking about why we'd started this work some years ago. And I think what I remembered was when I became the workforce officer for the RCPCH back in 2006, one of the first thoughts I had in that post was that we were seeing an expanding consultant paediatric workforce, and the figures for this are quite interesting. I'll run through those with you. So in 1928, we know that we had 51 paediatricians in the United Kingdom, and we know that because the 1928 was, I believe, that the year that the British Paediatric Association was founded, and that is the first census that we're aware of. Now, to give you a feel for that, my predecessor, Michael Simkis, was appointed in Poole in 1964, and for the first 15 years of his job, he single-handedly covered paediatric inpatient beds between 3 different hospitals across Dorset and Hampshire. And when I used to moan to Michael about the lack of junior staff when I became a consultant, he would remind me that he didn't have any in his day whatsoever. Now, to bring you up to date, the last census, 2015, showed that we had 3,996 paediatricians in the United Kingdom. So that's an eye-watering 6,800% increase in the number of paediatricians. Now, that feels like a big number. If you analyse it probably more appropriately, which is look at the compounded rate of increase, what you see is really a relentless 5% increase in consultant posts. So between 1999 and 2009, we had a 50% increase in paediatricians in the UK. For the last 2 census, between 2011 and 2015, we've had around a 4.5% increase. So we're seeing this constant increase in consultants. And I think the principles of Facing the Future was really to say that if we're going to have this expanding workforce, what standards can we achieve? And so the Facing the Future is really a link between the clinical standards, the workforce that you need to achieve those standards, and with the first set of Facing the Future, of course, around the configuration of services that we felt were sustainable to achieve those standards with the workforce. Now, the reasons for the expanding workforce are relatively easy to understand. We have around 400 trainees going into paediatrics each year. And our best guess is that we have around 90 to 100 retirements. Now, any workforce officer will tell you straight away that 400 paediatricians going into training will not equal 400 whole-time equivalents coming out the other end, but you will certainly get more than 100. So we're seeing this ongoing increase, and we would expect this to continue, albeit probably at a slower rate as time goes on. Now, one of the commonest questions that you're asked with the Face the Future when we present it is, what is the evidence for these standards? And if you look at developing standards. Standards can be pragmatic, they can be consensually agreed, or they can be evidence-based, and they can be around the structure, process, or outcome of the services. So the structure is what you've got, the process is how you use it, and the outcome is what you achieve. Now, in the ideal world, all standards, including service standards, would be evidence-based outcome standards, and then of course you wouldn't need a talk from me today because you'd know exactly what standards that you should be achieving. Now, I think what can be said of the facing the future standards is they're largely consensually agreed, and that's not to say that they're wrong, and I think colleges, in particular our college, is actually very, very good at getting consensual agreement across multiple stakeholders, and they're largely about the structure and the process of the service. And again, that's not to say that they're wrong, because getting the structure and process is right. You can assume that you will make improvements in the outcomes. Now, I think as the Face the Future work has gone on, I think we've spent more and more time, more and more disciplined at looking for the evidence base behind the standards. But when we did the first piece of work, which I did with Justin Thacker actually back in 2010, 2011, I remember that we spent the first 5 or 6 weeks of the project trying to look at the evidence for service standards around inpatients, and I think the outcome of that was we decided that there actually wasn't any evidence. So you might be interested to know the standards actually came from job descriptions from around the world, because what I'd realised is whereas UK paediatric job descriptions tended to be fairly, I suppose, boring, and they just offer you a job in pool and tell you how many sessions you'd worked, if you went to particularly North America, Australia, New Zealand, the job descriptions were much more prescriptive around you will be there at times of peak hours, you'll attend 2 handovers a day, you'll see patients within 12 hours. And it was actually going through, I think, about 200 job descriptions from memory that we actually started to pull out of those what we saw as good practice, which became the first set of standards. Now, finally for this slide, I just wanted to tell you what I think is an important rule with standards, and I stole this from my predecessor, Simon Lenton, and he had this concept of the 3Ms theory, which is standards should be meaningful, measurable, and motivating. And what that really means is that when you produce standards, I think there has to be something about those standards that gains the attention and I suppose the support of the people they're aimed at. So to give you an example of this, it'd be really easy to come up with one standard, which is be nice to children. And, you know, that's a great standard. Who's going to argue with that? After a while, someone's going to say to you, well, what do you mean by being nice to children? How do you know if you're being nice? When are we going to be nice? And I think that when we've produced these standards, we have tried to be somewhere between, I suppose, aspirational but not unrealistic. And I think to this day, I've been really, surprised, impressed with the way paediatricians have tried to work towards these standards to improve services. And I think they've done that because they believed in the standards and the commissioners have believed in them. So I think the strength of these sort of standards is sometimes not behind the necessary research evidence. It's about the fact that the paediatricians who we aimed at actually believe that they are the right standards and will improve services. Now, on this slide, I've just illustrated the 3 sets of standards as we have them. So the first set of standards was in 2011, revised in 2015. There were 10 standards around the inpatient care for children. Second set of standards, excuse me, Facing the Future Together for Child Health, I suppose you could say was really focusing on that issue that we were all struggling with a few years ago, was the rapidly increasing number of children attending, being admitted at hospitals with acute problems. And this set of standards was really aimed at trying not to admit children to hospital, and if you do admit them, to discharge them safely and quickly. And there were 11 sets of standards, and they were published in 2015. For the third set of standards, we were fairly sure this would be a straightforward one, and we would go for long-term conditions. I think that what we realised very quickly into the project was that there is a problem with that, because long-term conditions has a very specific definition, and by focusing on long-term conditions, we were going to ignore a large group of children who didn't have long-term conditions, and similarly a large number of children who had complex medical disorders. So we've changed the naming of the standards to ongoing health needs, and I think this is something about prompt, correct diagnosis, effective communication, improved self-management. Now, on the next slide, I'm going to take you back to 2013, which was the first audit 2 years after the first set of standards was introduced, and it was called Back to Facing the Future. I probably won't take you through all of the 10 standards, but I've picked out on this slide what I think are the high impact standards. So what we had auditing 4-hour to middle grade view, which was achieved in 77% of the children that were looked at. So the audit included a spreadsheet looking at times from when children came and when they were seen, and 77% was seen within 4 hours by somebody with middle grade competencies. Consultants seeing patients within 24 hours, which was the standard, was high. That was 88%. Consultant presence, and we defined here consultant presence during peak times, but allowing the units to decide what their peak times were, and that was probably a mistake in retrospect, because I think people would argue different peak times in the units apply. I mean, I guess nationally 3 to 10 p.m. on a weekday and 9 to 5 p.m. at a weekend is probably the peak time if you look at HES data. And what we had here was consultants, I suppose, wedded to their 9 to 5 working practices, and peak time presence was low at both evenings and weekends at 26% and 20% respectively. I think one of the standards that raised probably the most controversy at the time was the 10 whole-time equivalents on a training rota. To explain that standard, it was actually an extrapolation of a standard from 2004 from the Academy of Medical Royal Colleges. You remember 2004 was the first tranche of the working time directive when hours were reduced to 58 hours each week, and the Academy said that if you had 8 on a rota, then the average doctor in training would have 2 days during normal working hours when they'd be working, and they regarded that as important because that would be the time when the training would occur. So basically saying you shouldn't have too much time out of hours. So the standard that we had, 10 on a rota, was just a direct extrapolation down to 48 hours to achieve the same. Having said that, if you look at normal middle grade vacancies, which runs at about 25%, you'll see that that 10 becomes 8, and 8 is still a number where you can run, I think, a safe and sustainable and working time compliant rota. So I think, again, it's the right number, both from a training perspective and from a service perspective as well. Now, the outcome of that audit was in 2015, the standards went back through council, and the standards were revised so that we had 14-hour to consultant review instead of 24 hours, and consultant presence should be at 2 handovers a day. Consultant presence at 1 handover a day was around 94%, so that was high, but it was felt that it would be much more beneficial to have consultants present twice, and we'll come on to the audit of these latest standards as we go through the talk. Now, the next slide then introduces the new standards for ongoing healthcare. Now, when we started these standards, I think we had some intelligence around health services that I think directed the way the project developed. So we were aware that we do have relatively poor health outcomes for children in the United Kingdom compared with many parts of the developing world, particularly with Europe, and that's largely for long-term conditions and acute deteriorations in children's health. We know there are issues around boundaries. We know that parents and children can't understand why we don't work in a more joined-up fashion. We know that GPs feel that they get good service from paediatric departments when they've got very sick children, but quite often they don't get the information they need when they have children with less urgent problems, and that affects the way that they manage these patients, in particular the way they refer them. We know we have problems around transition, with health outcomes often suffering at the time children transition to adult services, and we know that children's psychological well-being is not always addressed as it should be. So with that in mind, we set up a multi-college project on this occasion with 5 colleges, our college, GPs, nurses, physicians and psychiatrists, and we started the work in 2016. The first year of the work was really, so a large part of this study was really around trying to look for the evidence from the literature as what standards we should be producing. We did multiple literature searches on children and young people up to the age of 24. We looked at 14 domains, including outcomes, prems and proms, education, attainment, relapses, admission, self-management. And from memory, we had around 540 papers that we reviewed. These reviewed in a systematic fashion. And then in 2017, we went on to try and produce standards. And I think, did the literature review result in the standards? I think the answer is probably no. Actually, I think these standards were still rather pragmatic and consensually agreed, but the literature review has certainly been very helpful in trying to underpin the evidence where it is available. In 2017, 2018, we had meetings of the group, we had stakeholders involvement, and as I think our college is very good at, involving children and young people as well. Now, the aims of the study were really, as I've listed on this slide, prompt and correct diagnosis, getting senior input, paediatric input earlier as we can in the pathway, better communications between children, professionals, primary and secondary care, better outcomes across health, education and social care, recognising the interdependence of these outcomes, connecting the whole system, integrating children and carers better into the planning service. And what we've also done more in this study than previously is we've tried to involve commissioners and health boards in the other 3 countries, because I think, again, one of the criticisms we've had with the work to date is that it's all very well coming up with standards if people don't commission the standards and provide the resources. So we have tried to be quite specific in the document about where we feel that health commissioners, health boards do need to become involved in delivering these standards. Who is the child? I think it's important to say this is not about primary care paediatrics. That would be a very, very different sort of development, but this is about getting general paediatric knowledge into the community. So it's about improving access to senior paediatric decision making, but not, I think, which would be a very different approach, would be trying to look at paediatricians working out in primary care. Now, moving on to the next slide, I've put at the top left of the slide, I think, 3 principles. I think the first is the standards really about working better together, and I think that underpins a lot of the Facing the Future work. I think for 2, I've often been, I think, surprised and impressed with this, that it doesn't seem to matter what standard that you ever come up with, somebody somewhere in the country has already thought of it and doing it. And I think a lot of the work we do in Face the Future is actually pulling together standards that, and pulling together ideas that are working well in practice and sharing those. And I think thirdly, it would be easy to dismiss this as standards that just apply to paediatric outpatient departments. And I think that would be a great shame. I do recognise that it may be more difficult to achieve these standards in community child health, particularly with some of the timescales we've set, but they are intuitive standards. I think they're sensible standards and actually should apply to all areas of paediatrics and medicine generally. On the right of the top of the slide, I've listed the way we've displayed the standards in the document. So we have the standard, we talk about who the child we're referring to, we talk about the aims of the standard, we talk about the rationale behind the standards, the evidence where it's available. I think what has been really helpful is we've collected evidence from around the country where the standards are being implemented already, and we've given practice examples, and then we've also produced metrics for to know whether you are achieving the standards and the difference those standards are making. That would be, I think, both for local units to use, and also, of course, for the college, which was likely to audit these standards within the next couple of years. Now, to come on to standards themselves, I think I learned when I presented the last set of standards in Birmingham that it's actually very difficult and not very inspiring to just read through 10 or 11 standards. So what I've tried to do here is try to group the standards, and I've actually wanted to talk really about the principles. I appreciate that many of you will have read the document where the standards are actually laid out. Now, the first and possibly the most important standards in this document is around trying to get decision making from paediatricians at the point at which the child is referred into the service. And I think we all recognise as paediatricians that once or twice a week we get a pile of referrals and we look at them and we tick them and we think we'll see the child in 3 months later and get stuck in. I think there would be huge benefits if we became, and certainly the word isn't responsible, I think the word is involved with the decision making from the point at which the referral was made. I think we all recognise referrals that we've read and we think, well, probably don't really need to see that one, but the current commissioning arrangements aren't particularly kind to you if you decide to do that. I think it's £270 if you see a child and absolutely nothing if you don't. Secondly, I think we've all seen referral letters and thought, well, if only the GP had done a few tests, that would be a much more useful consultation, and we don't feel empowered to do that. So the first standards actually are around the way we manage the referrals at the point that they come into the department. And although that might seem quite a unusual, novel approach, I mean, I can assure you there are good examples around the country where this is already being trialled, and you, as a general rule, around 40% of referrals probably don't get seen, they get managed in primary care. Around 40% are seen, around 20% are seen by a different specialist. So again, probably saving one consultation. I think in the time when outpatient appointments are at huge premium, I think that's a very useful way to look at services. Secondly, I've listed improved networking with tertiary care. You remember in the first set of Facing the Future standards, we talked about paediatricians having access immediately to telephone advice from tertiary care specialists. That was patchy, and in fact, as we'll talk about in the audit later on, it's still patchy. As you'd expect, oncology, cardiology and intensive care will provide that at 100%. Sometimes where we need advice as general paediatricians for respiratory problems, gastroenterology problems, endocrine problems, the rate of cover is actually much lower. We've reiterated the importance of immediate advice, but we've also talked about having advice within 3 working days for paediatricians from specialty services if they have asked for advice. So this again isn't about the acutely sick child, but it is about children where you feel we need to have a change in management. And again, there are good examples of that working in specialty services around the country. I think King's College Hospital in London is a good example of that. Thirdly, we've talked about single point of contact. There's absolutely no doubt at all that from the feedback from children and the parents, that is their big bugbear, that they cannot get through to people. There's answer phones, they don't know whether people get back to them. So we have stressed the importance of, for administrative issues, having a manned telephone service throughout the majority of the working week, and response within, I think we said 24 hours for those families who choose to leave messages outside those times. Clinically, also, we've suggested that information should be available. Now, this would be from referring doctors until the child is seen, or doctors, children and their families after the point the child is under the care of a child health department. And again, I appreciate that might be a bit of an eyebrow raiser, but there's no doubt that around the country there are systems developing where GPs, families can get information. That is important because I think we quite often find GPs are trying to make decisions they don't feel fully comfortable making, and at times when families know that they need information from the hospital but have no access, and there are all sorts of issues around here, around security, around confidentiality, and we try to recognise those in the document where we can. It doesn't really take much intelligence to work out that my email is david.shortland@pool.nhs.uk, and of course probably at least once or twice a day now we are getting emails directly from families. We have some services in hospitals that feel they actually couldn't cope without email interchanges, so we have tried to look at response times, which we've put at around 3 days again for clinical enquiries. That wouldn't have to be from the consultant, of course, that would be from a specialty nurse or a senior trainee. Now moving on to the next slide. We've spent some time talking about improving access to information. So we've looked at timescales and we've looked at the importance of all health practitioners having access to an appropriate minimum data set wherever they are seeing children. We know from the work, the audit that we did around the Facing the Future Together, that around 50% of people working in urgent care services have access to the electronic healthcare record. The other 50% don't. And we also recognise that whereas in hospital we take it for granted that you can access a child's health record, of course if you're working in community you often can't, despite the fact that technology is there. There are issues around security, there are issues around resources. We recognise the issue around more complex services where we have set a standard of 5 days for non-urgent communication. We do recognise that for multidisciplinary teams that's more difficult to achieve, but at least we feel we have stated what we we feel is an important standard. Now, for 5, I talked at the beginning about the importance of transition and mental health and psychological well-being. I think this is where it's very easy to come up with trite standards, which is, implement national standards. And I think what we've tried to do, again, probably true to Face the Future, is we've tried to be a little bit more specific, and we've had good help from RCP and RC Psych on this. So, for instance, if you look at CAMS, there is a document that clearly says for every 20 paediatric inpatient beds, you should have 0.2 WT CAMS practitioners, 0.2 WT CAMS nurse, and 1 WT clinical psychologist. So we've gone to the documents. There are some very good documents out there around transition, and we've tried to pull out of them the key standards that we feel need to be attained. We've tried to look at the resource in the department that would be needed to meet those requirements, and also for somebody to become responsible for ensuring audits, national standards are met. So I would hope that it's a little bit clearer than actually just trying to repeat, what's been said many times and arguably hasn't had huge impact. But we've been quite clear to actually state what should be achieved and at what level that should be achieved. Similarly, with the final standard really around co-design and effectiveness of care pathways, again, it's very easy to just make a comment around children should be involved in design, delivery of health service. And of course, that is difficult to achieve, and I don't think that will change very much, but we've been slightly more specific. So for instance, at board level, there should be a children's lead in all hospitals. Only 78% of hospitals achieve that. It's very interesting doing an invited review and asking the paediatricians who their board lead for paediatrics is, as very few people actually know that. In fact, I realised I didn't actually know that in Poole until quite recently. So I think it just says something about the impact these roles are having. And of course, putting a child on a board level, I think, would be tokenistic, but there are other ways, and the college has lots of work packages and things that they can help you with if you want to involve the children more in the design of your service, and obviously happy to share those with you. Right, now I'll come on now to the audit for so this is the final section of the talk now. The audit looked at the first 2 sets of standards, Facing the Future and Facing Together for Child Health. We sent out 161 surveys, and I think anybody who's been involved in an audit would know that a response rate of 121 is actually very good, and that, I think, largely due to the tenacity of Melissa and Danella, who have been running this audit. The part of the audit was complex in that you had to look at a case note spreadsheet to look at timelines for some of the standards, and that was a little more complicated. You'll see that our response rate has dropped to 60 cases for that, but it's still a relatively high number. I think we've been able to extrapolate from those data, and there were 14 site visits across the United Kingdom, all 4 countries, different types of hospitals. So we've been able to get, I think, what is a lot of good information face-to-face, talking to clinical directors and other senior healthcare professionals. Now, the last 2 slides, or sorry, the next 2 slides will give you the results of the audit, and I'll just try and take you through the standards that they pertain to very quickly as we go through. So consultant presence, weekday, evenings, effectively weekend, is still quite low. It's better than it was, around 10% improved on weekdays and weekends, but it's still probably lower than we would expect to see some 7 or 8 years after we'd made the first set of standards. But I do find from the invited reviews that I'm doing, particularly the ones I've done currently, that it does seem to be now more and more units are trying to address this problem and recognise the importance of it. There is huge support for that standard. I think it's just inevitably resources doesn't always allow paediatricians to deliver what they need to during the day and at the evenings. Middle grade review is almost unchanged. Sorry, it's not a problem with the slides here. Middle grade review almost unchanged at 79%. From memory, it was 77% previously. I don't think we'd ever expect that to be 100%, because registrars should not leave acutely ill children just to meet a standard for a relatively well child who hasn't been seen for 3.5 hours, but probably would have hoped it would have increased a little bit. Consultant review is interesting and disappointing, I think, at the same time. That's down to 48% from around 88%, and if you didn't do do anything, you'd expect children to be seen within about 50% seen within 14 hours just from the time that they come in with a once-a-day ward round. And I'm slightly puzzled by that data, particularly due to the fact that we are seeing more and more paediatricians trying to work evening sessions. So whether we're working the sessions but not changing our system so that children are seen, but that's a worrying figure, I think, because I think we're all believers in the fact that it is really helpful to see a senior paediatrician within a defined period of time. Specialty advice largely unchanged again, still 100% for the specialties you'd expect it to be, and probably around 60% for gastro, respiratory, and on endocrinology. And I think that again is important because it should be possible to work in networks, and paediatricians do need advice quite often, quite urgently, around children with these more complex disorders. I think below that we meet the standards to a relatively high degree. Middle grade discussion 94%, consultant support to an SSPAU for the hours it's open virtually 100%. Consultant of the week is 100%, but I think if you dig into it in practice, you'll find consultant of the week means different things to different people. To some people it does mean you have a consultant doing the ward round only on the assessment unit available. At other times you have a consultant who does a ward round and then does clinics. So it's not probably quite what we'd envisaged by consultant of the week when we set the standard, but it certainly is. We're getting there. 10 WTs on training rota. I think it was 28% in 2013 and it's 30% now. But it is interesting, this one, because if you look at tier 1 rotas, if they're combined, you have 9.7 average, and if they are just paediatrics, not neonates, it's 10.2, and the figures for tier 2 are 9 on a rota and 9.8. So I think we're actually very close to the 10 on the rota. It's just we don't quite achieve it, but the average is certainly around 9 now. So I think we have made a bit of progress. The safeguarding standard, again, slightly worrying in that it was 88% and that relates to standard of having somebody with level 3 safeguarding competencies able to see a child 24 hours a day, and that has fallen quite sharply from around 88% to 65%. We're not quite sure at the moment. I think we need to dig into those data because it may be something around a difference with the way the question was asked in the audits. Now moving on to facing the future together, which is the next slide, and you'll remember this is about trying not to admit children to hospital and those children that come in trying to discharge early and safely. I think we felt the high impact standard here, in fact the one with the best evidence actually behind it, was really that GP should be given immediate access to senior paediatric advice, ideally a consultant, up to extended working time, 8 a.m, 11 p.m. We suggested in the document 7 days a week. The paediatricians are achieving that. I think the worrying thing is in very few cases is it actually commissioned. It can be through dedicated hotlines, it could be through mobiles, it could be through emails, but I think paediatricians have worked hard to try and achieve that standard. The rapid access clinic, again, there's a huge, I think, variation in how you define a rapid access clinic, and I think we accept that in the standards. But with this, behind this standard, what we had in mind was that you would have a rapid access clinic within 24 hours led by a consultant, so that the GP wouldn't need to admit, because the child could be seen very quickly by a consultant the following day, and that figure's quite low at 26%. I think there was support for that standard, but it's clearly not being achieved in practice. The link paediatrician, probably to explain the role of this, this is something that probably many of you have done over the years. You go and have lunch with the GP practice because they've had an issue. Most recently for me, it was a practice that had had 2 empyemas in children over a short period of time. And I think it's a very useful educational exchange. It's not about acute information about a sick child. It's just about an educational liaison meeting. And we'd felt that there should be a link paediatrician to general practice. Depending on the number of practices paediatricians, it would alter how many practices each paediatrician would be probably linked to, but I would guess about 3 to 4 looking at Norton, the numbers we have around the country. That is great support for that. I think neither the paediatricians think they have the resource for it, and the GPs don't think they have the resource to take it on either. So it was a standard that was supported but really not being met. 6 monthly educational sessions where urgent and scheduled care can be discussed, jointly produced agendas, 50%, pretty well. CCN support 24 hours is low. We didn't envisage community nurses driving out and seeing children in the middle of the night, but we did envisage being available for telephone advice. Now, clearly, if CCNs don't provide this, SSPAUs do. So there is some nursing support, but you'll see from the figures that it's just worryingly low, the number of services that have 24-hour community nursing support. And I think if you're going to admit children earlier and safer, that's probably what you need to do. The Link CCN, similar principle to the Link paediatrician, is running at about 10 or 11%. GPs weren't actually too fussed about that standard. I think they felt that they would like to have a CCN to talk to, but not necessarily a single one. Discharge summary to GPs, you might expect, is fairly good, 76%. Verbal and written safety netting, 84%. Difficult to encompass in a single standard, but it's just to say that units have some safety netting around the common conditions. Access to the electronic healthcare record, alluded to that previously, that's running at 45%. So that's people in urgent care settings, around half can access a minimum data set on the child. I was quite surprised about the care pathways. That was only 17%. I think we identified 6 high impact urgent care pathways in the document, and only 17% of units have even one of those agreed between primary and secondary care. And again, documented meetings on unscheduled care is low. Those meetings, again, are probably overall not particularly well attended, not particularly well minuted. So again, probably some issues around that. And this was a meeting that was envisaged where you would have relevant stakeholders, young people, looking at urgent care metrics and seeing how the service is being delivered. Okay, so moving on to my final slide. I think over the years, as mentioned earlier on, I think I have been really impressed by the way the standards have been taken up by paediatricians. I think there is a willingness for paediatricians, health professionals, to use standards to improve health outcomes. It is to reiterate that Facing the Future standards are largely consensually agreed standards around the structure and processes of services. I'm afraid evidence base for service standards is difficult to achieve. The audit, I think, is important. It's important we know how the standards are working in practice. I think they're important for departments to improve standards by benchmarking themselves against other units, by sharing practice, and it's important for the RCPCH to drive improvements. And finally, if you haven't spotted it already, child health services are under pressure and under-resourced. Now, I've just been asked to show you a couple of final slides, and I'll stop talking. The next one is just to say that there's a new set of Facing the Future standards. The paediatric emergency medicine standards are being presented, I think are being launched, on the 5th of June. So you'll receive the circulation soon about that. The next slide is just say Dr. Akindoli she did an excellent presentation at the Glasgow meeting looking at the Facing the Future standards in practice and discussing implementation, what they can achieve. And I think she's planned to do a webinar on the 8th of June. And just finally to say that, as with all the RCPCH work, we do involve young people, carers, at a very high level in the projects. And if you did need any support or packages or any information related to their input standards, you'd be welcome to contact Melissa at the college. Okay, thank you.
Thank you very much, David. That concludes the presentation. So we will move on to some questions now. We've got one here from Bengusu, who says, what is the recommendation for the rapid access clinic? On our unit, we see them within 48 to 72 hours.
I talked to this. Yeah, thank you for the question. Yes, it's a good one, isn't it? There's a real issue, I think, around rapid access and what it means. I think a lot of rapid access clinics are just slightly quicker than an outpatient clinic. I think services are probably abused, if I want to put it that way. It can be used as a bypass around waiting lists. I think we had some comments from paediatricians around this particular standard that they don't feel always it is a good use of resource, because it just means that some GPs use it, some children are seen slightly sooner than others. And I think in many hospitals, rapid access would be regarded as anything between maybe 1, 2, 3 or 4 weeks. And that's fine. I think if you have a system, I think that's better than waiting 6 or 8 weeks for a routine outpatient appointment. I think with this rapid access clinic related to this particular standard. And I think this is where the confusion is, because a lot of people have rapid access clinics. I think this was something about being able to be seen by a consultant within 24 hours. The logic of this is that the GP with a child with, let's say, a large head can talk to a paediatrician. They won't admit the child that night because they know the paediatrician will see the following day. And I think our feeling was, if that service was implemented, that would have quite a significant impact on attendances. I think some services that we've seen, in fact some when I've done invited reviews, have actually set up a service where that happens 7 days a week. I think many services, probably like you're suggesting almost in your own services, it's actually doing some very good work if you're able to see children within 2 or 3 days. I think the question you have to ask yourself is, does that prevent an admission? Because if you think of Facing the Future Together, it's largely about children not being admitted because there is a plan B. I think that if you're seeing children within 2 or 3 days, I suspect what you're running is a very effective rapid access clinic, and you're clearly resourcing it very well. But would a GP not admit tonight because the child can be seen tomorrow? I mean, there are some systems where NH111 can book directly into rapid access clinics, so they can actually access that service directly through the GP without going through the paediatricians. So I think that ideally, the standard as it stands would say within 24 hours, and I think what you're doing is offering very, very good access to patients. It probably isn't quite in line with the standard, which is not to say that it's wrong. It just may not be achieving a maximal input in terms of. I think we recognise that a lot of GPs will admit a child because they don't quite know what's going on. I think if they can talk to the consultant and have the child seen the following day, then I think you would have an impact. I mean, I think there is evidence out there as well to support that children would not get admitted but would be seen the following day. But it is a resource. I mean, I suppose my feeling from looking at the audit, the hospitals that have achieved this have around 3 sessions each day where the consultant of that day can see patients as they attend the SSPU.
Thank you, David. We have another one here from Anika. I am a paediatric registrar with an interest in transition to adult services. The real challenge seems to be access and link to adult services. Please could you advise how we can get support for implementing Standard 6?
Yeah, Anika, thank you for the question. Anika, it's complicated, isn't it? I mean, it's really pleased to hear that you have that interest because it's just so important transition. Anika, we worked closely with the RCP. In fact, the RCP have had a work stream, I think, which I was on. I think subsequently, Carol, my successor, has been on for many years looking at transition. There are some very good documents out there, not least produced by the Department of Health. I think, and you're very welcome to sort of email me outside of this talk, and I'll try and help you in a little bit more detail with this if I can. But I think that what we've tried to do with the standards is try to identify around transition what are the key documents, but also personally, I feel that, and I think we said 0.5 WTs in the document for all specialties. My own feeling on this is the way to start getting transition right is to have somebody, and I'm inevitably going to say working within the paediatric department, whether that's a doctor like yourself or a senior nurse or nurse practitioner who's actually, I suppose the word is, responsible for ensuring smooth transition. I think if you allocate the time for that person, I think if you have the right person in the job, I think if you can get the links between that person and the relevant adult services, I think if you can set up joint clinics, so for instance things like cystic fibrosis where you have quite a few children coming through the big transition, I think you can have joint clinics which will be very successful. I appreciate for something like maybe neurology that's more difficult, but Anika, I think it's having the person who wants to do the job. I think it's having the time recognised. I think it's that person knowing what the key documents are. I think it's auditing against those key documents. I think it's getting the ear of the commissioners, and I mean, there's no doubt at all that, you know, and this is well published, that, you know, children, nephrology is probably the one that sticks in my mind. Renal function deteriorates around transition sometimes if it doesn't go well. So I think the evidence is out there, but I think what we've tried to do in the document is try to say that I think you need somebody probably, I don't know what size hospital you work in, but I'm probably going to say in an average department half the whole-time equivalent who's actually responsible for transition. And I think if you have that, and obviously somebody maybe like yourself with an interest, then things will move forward. Inevitably, it's patchy in some specialties, but I think the documents are good. It's just they're not being implemented at the moment. But if there's anything around, there's a lot of work on the RCP stream, so you're welcome to by myself or the college, and we'll try and help you with that. And we had really good input. I mean, the reason for involving RCP actually with the whole project was around transition, and I think they were really very keen to have something said in this document, because originally we'd felt that the RCP have said it all before, but they were actually really keen to do this work. So there's huge support, I think, for what you're suggesting. It's just the reality is it gets lost in the mist if you don't have somebody with the resource to deliver that, really.
Thank you. And one more from Prakash. Are there separate standards for standalone paediatric assessment units which are attached to adult ED?
The answer is simply, Prakash, is yes. The standards were produced last year by I can't remember from memory, I think it's about 40 or so standards in them, Prakash. It's a good document. It's on the RCPCH website. It was, in fact, I was on the work stream that produced the document. So the answer is definitely yes to your question. What I think is lacking, which we're actually working on at the moment, is probably a dashboard for SSPAUs, because I think there's something about having the standards but also seeing in practice how those are working. So that is work in progress. You raised that really important question, don't you, about whether they should be co-located with the paediatric department or co-located with the ED. There was a paper, I think, by Fee and Davis on SSPUs. I think we're going back about 6 or 7 years, probably even longer actually, that did look at the practicalities of the way the two units work, because they do work differently. I do quite a lot of reviews for the college, and I'm very familiar with these two different models, and they do tend to work, I think, subtly differently. I think the standards, Prakash, probably should be the same, and they're very clearly listed in the document. There are a lot of standards. I think it's actually a good piece of work. It's very up to date as well. So I think if you have a look at the document, I think that'll answer your questions. I think that what you will find is if your SSPU is co-located with an ED, it will have a slightly different function from those co-located with paediatric wards. I think my gut feeling from all the ones I've seen is probably they are slightly more effective co-located with the paediatric department, but I'm sure there's many people that would disagree with that. But yeah, Prakash, have a look through the document, and any specific questions, you're welcome to come back to me, and I'll try and answer those in a bit more detail for you.
Thank you. And one more for you. When working with primary care, such as the link paediatrician or educational meetings, the practices which engage are often not those that will benefit most. For example, practices with a pre-existing good working relationship and interest in paediatrics. From your visits, do you have any practical examples of how units have engaged some of the more resistant primary care colleagues?
Yeah, I'm just going to break off a second, so I just have a quick read of that question as well. So just bear with me a moment. It sounds like a very interesting question. Yeah, thanks for that question. I think it's a good question. I think inevitably is going to be true. I mean, there are practices that I think currently do have good links with paediatric departments, so some maybe less so. I think the problem, or from the audit of this a particular standard, what we found was that there is actually huge support for the link paediatrician. I think there is a little bit of confusion possibly what the role is, and I would emphasise this is not about I need advice about a child today, where's my paediatrician. I think that is clearly something that's not going to work. I think this is more of a developmental, educational, I suppose, relation type developing. I don't think we picked up from the audit that there was antithesis really to that standard. It was just inevitably that the paediatricians don't feel they've got the time. I think the GPs, again, we've got to remember that, you know, if they give up time for these meetings, they sometimes have to pay locums to deliver the work, and we are aware of that, and obviously very sympathetic to that. If you've got a pen on you, there's a David Levy, I think, or Levi, Levy, who works in Tameside, which I think believes Manchester, and he's provided a good example, and he's apparently was happy to be approached about this. So if you were interested to take that further, because I think this is where practice examples are really good, because I think your question is, did you hear it? Okay, sorry to apologise, I muted my mic. Okay, sorry to apologise for that. Yeah, so the answer is a really good question. I think from the audit, there was pretty widespread support for that standard. I think I would emphasise it's a developmental relationship learning types, and I do this myself from time to time. It's not about, you know, I've got a sick child, I need somebody to say, where's my paediatrician? The problems, I think the paediatricians feel it's a little bit soft compared with everything else they're trying to do during the day. The GPs feel that if they can't see the patients, they have to get locum. So I think there are barriers to that, and I understand that. 7% is actually very, very low. I think there are people, I suppose, like myself, I've probably 2 or 3 times a year I'm approached by GPs, and I don't consider this a formal link, but we do it. What I did want to mention to you is there's David Levi, Levy, who works in Tameside in Manchester, has said to us that he's found this very helpful, and he's happy to give you examples of how it works in practice. So if you're interested in pursuing that, then maybe contact Melissa Ash at the college, and they should be able to put you in touch with him. But he was said that he was happy to be approached. But yeah, I think it's I think it's a standard that probably was accepted, but lower down the priorities than others, really. But if you are finding certain practices that maybe don't see the advantage in that, I would probably suggest it's because they've never had somebody maybe around the table talking to them, which they would find beneficial. I mean, when I've done this in the past, it's always been, you know, I think it's been beneficial actually on both sides. I think we learn a lot from talking to GPs as well, actually.
Thank you. And the final question, how can standards be used by paediatricians in conversations with service planners and medical managers?
Yeah, thank you. Okay, I mean, when we've produced the standards, we've had commissioning input, and I think it's true to say the commissioners are universally positive, and I suppose we should say obviously health boards as well, because in the other 3 countries they don't have commissioners. The commissioners of health boards have been universally positive. I think they are looking, as CQC did, they're looking for professionally agreed standards that they can benchmark services against. And I think the good thing about the Face the Future work is it's developed a sort of I suppose, a reputation that the standards are helping. I think it would be, in the first instance, inevitably being aware that your commissioners are aware of the standards, and we are just, as we talk at the moment, just preparing to send the latest sets of standards out to commissioners. So we always make sure the standards go to them. The next problem, of course, across their priorities, which were much more aimed at adult services, stroke, cardiovascular disease, is actually try and get children on the agenda, and that often depends on the persons that you're dealing with at the commissioners. So I think the first thing is, I think the standards have been written, they've been developed, you know, co-developed with commissioners on the groups. I think if you make the commissioners aware of the standards, because I can promise you that they'll have so much going on, probably bigger fish to fry, they won't necessarily come to you looking for discussions, but if they do, then I think the standards, I think the audit of the standards is really important. What you will have in your department already is your benchmarked audit against the first 2 sets of standards. Obviously it's too early for the 3rd set of standards to have been audited, but those I think are quite powerful, because they will tell you whether you're meeting the standards, and they will tell you how much of an outlier you are. And I think it would be foolish, maybe, you know, rare for commissioners to just ignore that altogether. I think commissioners respond well, in my experience, to, they have to be highlighted that there is a problem. I think there have to be a solution. I think, generally speaking, going to commissioners with the evidence with professional standards, with the evidence of where you are and where you are against the standards, I think you would probably get the RIA with that, actually. But if you haven't, it will have gone to the clinical director in the department, but you will have what I think is a very nice 2 or 3 page document around these 11 standards that we've audited against, and where you are benchmarked. And if you are a complete outlier, then I would suggest that the commissioners will certainly be interested. But I think the key thing is try to go with them with the evidence, and try to go with them with the solutions. Don't you obviously just go with the problem. Try and go with what it would take your department to be able to meet these standards.
Thank you very much. So that concludes the question and answer session, and as such the webinar. Thank you for joining us today. And for those of you who have, you'll receive an email with a link for you to give feedback on today's webinar. So if you'd like to fill that in, that would be great. The webinar will also be available on our online classroom Compass for 1 year, so you can access it there after today. So if you would like to submit any further questions on today's webinar, you can send these to health.policy@rcpch.ac.uk. And if we haven't got round to answering your question today, we will follow up via email. Thank you very much for joining us.